Welcome to the Deep Dive. Today we're really opening up the files on a topic that's, well, scientifically dense, but also deeply important, testicular cancer. We've gathered quite a bit of material here, sources covering, everything from potential environmental triggers right through to the latest in diagnosis and treatment.
That's right.
Our mission really is to cut through some of the noise and give you the critical synthesized knowledge from all this stuff.
Exactly. And when we talk about testicular cancer, just for clarity, we mean cancer starting in the tissues of one or sometimes both testicles.
Right.
But like you said, the goal here is to go way beyond just that definition. We want to uncover some of the, frankly, surprising risk factors, decode the biology of the different tumor types, because that matters a lot, and lay out the diagnostic and treatment paths clearly.
Okay, yeah, let's unpack that. And we're hunting for those nuggets of info that take you from just general awareness to, a properly informed understanding. And I think you're right, the risk factors. They seem much broader than people might think.
Yeah.
And the biology differences, how they dictate treatment, that feels key.
That's where the critical insights really are.
So, standard practice for us. Let's start with what we don't know. The ultimate cause, the specific etiology of testicular cancer. It's still unknown. Right?
Yeah, it is, yeah. That fundamental why remains elusive. It's a significant gap in oncology.
What do the sources point to consistently? What are the established medical risks?
Okay, so the literature we looked at is pretty clear on the big ones. Right at the top consistently is cryptorchidism.
Which is when the testicles don't descend properly.
Exactly. One or both fail to descend.
Yeah.
That's widely seen as the single most significant risk factor. After that, you've got underlying genetic factors playing a role and certain specific disorders related to how the testicles develop. Those are major contributors too.
Okay, so those are the sort of internal biological predispositions. But this is where, looking through the material, it took a really unexpected turn for me. The sources list this just incredible range of external environmental factors, things that seem totally separate from genetics. It almost reads less like a medical profile and more like, I don't know, an industrial safety sheet.
You're spot on. It's fascinating. Beyond the biology, the documented exposure risks include things like industrial materials, tar, pitch soot, stuff related to gas production, even heavy contact with lubricating oils.
Wow.
These suggest a pretty powerful, though maybe not fully mapped out, environmental or occupational connection.
Wait a sec. You've got industrial chemicals, but the list also mentioned things like poor hygiene, chronic inflammation, even HPV and sunbeds. Are these all considered sort of equal risks, or is it just a collection of possibilities?
Well, that's the interesting part. The sources tend to present them as sort of cumulative potential risks. They definitely don't carry equal weight. Cryptorchidism is still the big one. But it shows just how many different things might potentially disrupt cells down there. And yeah, lifestyle factors are in the mix too. Poor hygiene potentially leading to chronic inflammation, HPV infection, use of sunbeds, and interestingly, exposure to photochemotherapy.
Okay, hold on. Photochemotherapy, that's often for skin conditions, like psoriasis, right? Why would that pop up as a risk factor here? Is the idea just chronic stress or damage to cells in that area?
That seems to be the thinking. It points towards the idea that basically anything causing significant stress or damage to the testicular tissue, whether it's, long-term industrial toxins or even therapeutic radiation aimed at cell division, could potentially nudge things towards malignancy. So understanding this really broad risk profile shifts the focus a bit, doesn't it? It's not just about genetics, it's also about being aware of environmental and, other exposures too.
Okay, so if nailing down the absolute why is tricky, let's pivot to the what. The actual tumor itself. The sources are really emphatic that about 90% of malignant tumors here are germs cell tumors, GCTs.
Yes, that's fundamental.
And that fact alone, that the cancer starts in the very cells meant to create sperm, meant for reproduction, that feels inherently, strange.
It really is. It's like a malfunction at the body's most foundational level, in cells programmed for creating life. And within those GCTs, the absolute key distinction clinically is between seminomas and non-seminoma tumors.
Okay.
Seminomas, generally speaking, are made up of a fairly uniform population of cells. They arise from the seminiferous epithelium, the sperm-producing tubes.
Uniform cells.
Yeah.
And the non-uniform ones. The non-seminomas.
Right. Non-seminomas are kind of the opposite. They're usually less differentiated, meaning the cells look more primitive, less specialized. And crucially, they often contain more than one type of malignant cell. This difference in sort of cellular appearance and mix is probably the most critical piece of information to grasp here.
Why? Why is that distinction so vital for the patient's journey?
Because it dictates the treatment path, especially after surgery. Seminomas tend to be highly radiosensitive.
Meaning they respond well to radiation.
Exceptionally well, particularly for localized disease or smaller recurrences. Non-seminomas, on the other hand, are typically radioresistant. They usually demand pretty intensive chemotherapy, often involving multiple drugs. So you treat them very, very differently based primarily on what the pathologist sees under the microscope.
Got it. Okay, now diving deeper. This is where it gets really specific and honestly quite fascinating. Within that non-seminoma category, there are these outliers. Let's talk about choriocarcinoma. The biological link the sources mention is, well, it's stunning.
Choriocarcinoma is rare, thankfully, because it's highly aggressive. But the key biological point, the surprise, is that it's essentially identical, cell for cell, to tumors that arise from placental tissues.
From the placenta.
Yes, it's a cancer made of cells that mimic pregnancy-related tissue. It really highlights how these germ cells, these potential sperm cells, can sometimes kind of revert to an incredibly primitive state, capable of making structures meant for entirely different biological jobs. It's quite profound biologically.
Wow. And then the other really strange one, teratomas. The name itself sounds ominous, monstrous tumor, but they're usually benign. And they're made up of, well, bits of everything.
That's right. They're described as composed of somatic cell types, like normal body cells, from 2 or even all 3 embryonic germ layers. So you might literally find structures resembling hair, bone, cartilage, even teeth within the tumor.
Teeth. Inside a testicle tumor?
It sounds bizarre, but yes, the teratoma is almost the ultimate, albeit chaotic, demonstration of the germ cell's potential. It shows this disordered but differentiated growth, trying to make bits of ectoderm, mesoderm, endoderm. It really underscores how fundamental and sometimes how weirdly mistaken that early cellular programming can be.
So understanding these subtypes to differentiate the cell origins, that's crucial for prognosis too, right? Not just treatment.
Absolutely. Poorly differentiated non-seminomas, for example, generally carry a higher risk of spreading, of metastasis. So yeah, subtype matters immensely for predicting outcome.
Okay, let's shift to detection. What do the sources say about the early local signs? Early detection seems absolutely key here.
It really is paramount. The symptoms often start quite subtly. The most common primary sign is usually a painless swelling or just a small, firm lump or mass on the testicle. Sometimes it might eventually ulcerate, but often it's just there.
Painless is a key word there.
It is. Other common local signs can include a sort of dull ache in the lower abdomen or the groin, maybe some pain or swelling specifically in the testicle, or sometimes just a feeling of dragging or heaviness in the scrotum. But that lack of initial pain is critical. It means guys might ignore it for a while. Regular self-exams are so important because of that.
And that delay, that lack of pain leading to delayed presentation, that unfortunately allows time for it to potentially spread for metastasis. If the cancer has moved beyond the testicle, what are the more serious systemic signs the materials highlight?
Right. If it's metastasized, the signs change and often relate to where it's gone. For instance, swelling in the lower extremities, the legs, can suggest it's spread to lymph nodes in the abdomen or back the retroperitoneum, and they're pressing on blood vessels.
Okay.
Back pain is another classic sign of that retroperitoneal lymph node involvement. If it's spread to the lungs, you might see a persistent cough or even hemoptysis, that's coughing up blood.
Serious signs.
Very. And then a lump or mass in the neck could indicate spread to lymph nodes there, while dizziness might suggest, though less commonly, spread to the brain.
So when these symptoms, or maybe a self-exam finding, triggers a doctor's visit, the diagnostic workup begins. What are the key tools and findings mentioned in the sources to actually confirm the diagnosis?
It starts, as you'd expect, with a thorough physical exam and getting a detailed urologic history. Then imaging is absolutely essential. First step is usually a testicular ultrasound.
To look directly at the testicle.
Exactly, to visualize the mass. That's followed by a CT scan, typically with IV contrast dye, to check for any spread, especially to those retroperitoneal lymph nodes in the chest. Sometimes an MRI might be used for more detailed local assessment.
And then the blood tests. These seem really important, relying on specific biomarkers. Just listing acronyms isn't that helpful, though. Can you break down what those elevated markers AFP, beta-HCG, LDH, PLAP actually signify?
Yes, this is really critical information from the blood tests. These are tumor markers. Elevated alpha-fetoprotein, or AFP, elevated beta-human chorionic gonadotropin, beta-HCG, elevated lactate dehydrogenase, LDH, and sometimes elevated placental alkaline phosphatase, PLAP. We test for them because their levels often correlate strongly with specific tumor types and the amount of tumor present.
How specific are we talking?
Pretty specific, actually. For example, AFP is typically elevated in non-seminoma tumors, particularly those with what are called yolk sac elements.
Hmm.
But crucially, it's generally not elevated in pure seminomas.
Okay, so that helps differentiate right away.
It does. Beta-HCG, which most people know as the pregnancy hormone that's often significantly elevated in choriocarcinoma, given its placental link, but also in some seminomas and other non-seminomas. LDH is a bit less specific. It's more a general marker of high tumor burden or rapid cell turnover, often indicating more advanced or aggressive disease. PLAP is another marker sometimes seen more with seminomas.
So the pattern matters.
Exactly. The combination of which markers are elevated, and by how much, is essential for the initial staging, for helping determine the tumor type even before surgery sometimes, and then, very importantly, for monitoring how well treatment is working later on.
All right, so diagnosis confirmed, tumor type identified, stage determined. What do the sources outline as the standard treatment pathways?
Well, the initial step is almost always the same, pretty much regardless of stage. It's a radical orchiectomy.
Which is the surgical removal of the affected testicle.
Correct. And it's crucial, the sources emphasize this, that it's done through an inguinal incision, a cut in the groin, not directly on the scrotum.
Why is that detail so important?
It's about minimizing the risk of spreading tumor cells locally into the scrotum or disrupting lymphatic drainage patterns. Doing it via the groin allows for proper control of the blood vessels and spermatic cord, and it's considered the standard for accurate staging and oncological safety.
Okay, so that's the primary step. But as you mentioned earlier, depending on whether it's a seminoma or non-seminoma and the stage, other treatments are often needed. What's on that spectrum?
Right, the orchiectomy is usually just the beginning. What follows depends heavily on the pathology report and staging scans. For, say, a very early stage, low-risk seminoma, the next step might just be active surveillance watching closely. Or maybe some adjuvant radiation therapy to the retroperitoneal lymph nodes.
And for more advanced disease or non-seminomas?
That usually requires more aggressive approaches. Advanced seminoma might get chemotherapy. Non-seminomas, especially if they've spread or are high risk, almost always require chemotherapy, often intensive multi-drug regimens like BEP chemotherapy. And then there's another major surgical option, retroperitoneal lymph node dissection, or RPLND.
To remove those abdominal lymph nodes, where it often spreads first.
Precisely. It's a complex surgery, but it can be both diagnostic to see if cancer is actually in the nodes and therapeutic to remove it.
And there's one more really critical point, almost a logistical step, but with huge life implications, that you pulled out from the sources. The need for cryopreservation before treatment starts. Why is that non-negotiable?
Yeah, this is absolutely vital and needs to be discussed up front. Cryopreservation means sperm banking, collecting, and freezing sperm. It has to be addressed immediately before starting chemotherapy or radiation.
Because those treatments can cause infertility.
Exactly. Especially the chemotherapy regimens used and radiation involving the pelvic area carry a very significant risk of causing permanent infertility. So offering sperm banking before treatment begins is crucial for preserving the patient's future options for having children. It's a cornerstone of comprehensive patient care, looking beyond just treating the cancer itself. Hashtag tag tag outro.
Wow. Okay, this really has been a deep dive. We've gone from, surprising potential risk factors like industrial exposures, tar, gas production, all the way through these incredibly nuanced biological distinctions. Like telling tumors apart based on whether they raise AFP or HCG or that, frankly, bizarre link between choriocarcinoma and placental tissue.
It is quite a journey through the science, and what really stands out, I think, is the sheer complexity that arises from that single origin point.
Yeah.
The germ cell. The fact that 90% of these cancers come from these incredibly foundational cells capable of such wild, chaotic differentiation, it really underlines how unique this particular cancer system is.
Yeah, that complexity is striking, which leads perfectly, actually, into our final provocative thought for you, the listener, to maybe mull over, given what we learned about teratomas, that they're usually benign, but can contain fully formed somatic cells from different germ layers, things like hair, bone, even teeth. What does that incredible, strange, sometimes chaotic cellular mix-up tell us about the raw foundational power? And maybe the occasional developmental glitches inherent in our body's earliest, most basic cellular programming?
That's a powerful question to end on. Lots to think about there.
Indeed. Thank you for joining us for this deep dive into the sources. We'll catch you next time.